That'll wake you up anyhow to get it started. Anyhow, I want to welcome you all, and I want to congratulate Mary and the Miracle of Living Committee. They just always have such great presentations, and I think it works so well for the community. And I appreciate your turning out. I know there's some people on Zoom, but it's nice to be here in person, and you'll get to meet some of these amazing doctors. I think want me to start over? No. He's my man. This guy takes care of everything. I don't need that, do I? Anyhow, so you see that this program is about sleep and the heart. And I think I won't dwell on it. We have two experts here, one for each organ. But I think the thing that I've been learning, as opposed to when I was in practice, how when you read all the things that you want to avoid the aging process, or at least decrease its rapidity, the sleep is one of the most important medicines that you can get. And then the relationship to the heart, I think, is critical. So we'll get started. I think you'll want to hear these guys speaking. First, we'll have Khalid Eltawil. He's been here for 23 years. He's got his bachelor degree, University of London, medical degree at Cairo. Then the rest of his practice, internal medicine, which he's board certified, pulmonary, critical care, and sleep. He trained at LA County, USC. And he's here to first give us the outline of what's needed and what's important about sleep. And everybody's got to be awake when this is over. A couple warnings. Please put your phones on to silence. And the way the program will be is we'll have a break at the end of their talk for about 3 minutes. You'll have time to write questions and people will pick them up, and then these guys will answer them. Thank you.
Thank you, Dr. Lurie. I will not take offense if anybody falls asleep. So as Dr. Lurie mentioned, we're here to talk about sleep, particularly as it relates to the heart. Just a little bit about myself. I'm a pulmonary critical care physician, and I work with 6 other pulmonary critical care physicians. We just moved to our brand new office in the Lundquist Lurie Cardiovascular Center, and Suite 200. There's 2 of us who specialize in sleep, and we just recently had an addition, Zoe Armas, who joined us. She's a nurse practitioner who's also focusing on sleep. All right, so we're here to talk about sleep, particularly as it relates to the heart. The question is sleep really important? Is it, Dr. Lurie mentioned how important it is, but is it really important? Well, for a long time, people didn't really know what sleep was. They thought it was, you have a battery, it empties out during the day, and then you go to sleep at night just to fill out that battery. And Edison actually had this quote. He described sleep as a criminal waste of time inherited from our cave days. That's how insignificant it was at that point. And for a long time, that's all we knew about sleep until REM sleep was discovered. REM sleep is the period of night where we have rapid eye movements. So once that was discovered, we started realizing that sleep is not just an empty battery. It's not just a passive process. It's a very active process. There's a lot of chemistries and processes and centers being activated, and they all work together in a very precise manner to make us go to sleep. So the way I look at it is, at any given time during your day or night, you have certain processes or chemistries that want to put you to sleep and others that want to wake you up. And the balance between the two determines whether you're awake or asleep at any given moment during the day. So I'm going to talk about a couple of these processes which are important to understand. The first one is called the process S, or our need to sleep. This is very simple. So if you look at this graph, the dark lines are nighttime, the white part is the daytime. So this person wakes up around 6 in the morning and goes to bed around 10 o'clock. And from the time he wakes up, the need to sleep, as long as he's awake, the need to sleep keeps increasing and increasing and increasing until 10 o'clock at night. His need to sleep was really high and he falls asleep. Now, once he falls asleep, that need to sleep goes down, and that is why if you wake up in the middle of the night, sometimes you have a hard time going back to sleep again. That's one of the reasons that happens. So The reason this is important is, or the way this works is that there is an enzyme called, or a chemical called adenosine. This is the chemical that seems to make us go to sleep. It's very important for our sleep. And during the daytime, it's attached to these 3 phosphate bonds, and it's called ATP, or adenosine triphosphate. That's where the energy that we need to function is stored. So during the daytime, as we go about our day, we break out these bonds and release energy that makes us function the way we need to function. And then at the end of the day, you have this free adenosine just circulating around in your body. And this adenosine is a sleep-promoting agent. It helps us go to sleep. It hooks up to certain receptors in the brain, and when it hooks to these receptors, it makes us go to sleep. So the longer you're awake, the more adenosine you have in the body, and the more sleepy you get. If you do take a nap in the middle of the day, during that nap, you recreate the phosphate bonds and energy, the ATP that you had before, and this adenosine decreases in level. So that's a reason why if you take a nap on the couch before you go to sleep at night, or watching TV, you nap, or take a nap in the afternoon, it may be hard to go to sleep at night when it's time to go to sleep. And this is also how coffee works. So the caffeine molecules look just like the adenosine molecules. They're identical. So when you have some coffee, the caffeine goes to the adenosine receptors and blocks them. So you may have a whole lot of adenosine circulating in your body, but they can't get at the receptors, so you stay awake. Eventually, they break off, and the adenosine puts you back to sleep again, but for the duration of the time where the receptors are occupied by the caffeine, you will be awake. The other process, which we call the process C, or the urge to sleep, this is a little bit different. This is our biological clock, or our circadian rhythm. So there is a clock that is located in the brain. We know exactly where that clock is. It's right above the eyes in this area called the suprachiasmatic nucleus. This clock tells us exactly what to do and when to do it. It tells us when to go to sleep, when to wake up, when to eat, and so forth. Everything in our body is controlled by that clock. So one of the things that is controlled is this other gland at the end of the brain called the pineal gland. This gland releases melatonin. That's what its function. And melatonin, we all know, helps us go to sleep. So during the daytime, there are certain light receptors in the eye that respond to the sunlight or any bright light out there. And when these receptors are stimulated, they send a signal to this clock to tell it it's light outside. You need to be awake. So in turn, the clock sends the pineal gland a signal telling it, you have to stop producing melatonin. It's light outside. You need to be awake. So during that period of time, there's no melatonin in the body and you're awake. Once that becomes dark and you no longer have this light signal, then the melatonin starts coming out again and you fall asleep. So if you take that same person who wakes up at 6 in the morning and goes to bed at 10, you'll notice that during the nighttime, the amount of the urge to sleep is higher as opposed to the daytime where the urge to sleep is lower. Except for a small bump around 6 to 8 hours after you wake up. We're not sure why that happens, but the urge to sleep seems to increase, and it seems to happen right after lunch for some reason or the other. And this is the time where if you needed to take a nap, you can easily fall asleep. In the European history, that's when that siesta happens. People are much easier falling asleep in that time. So as the night progresses, it starts turning dark at 8 o'clock, for example. This person has been up for a long time, so the need to sleep is high. It's starting to become dark, so then the urge to sleep is high, and when both of them are up there, he ends up falling asleep. So once he's asleep, we go through cycles. So we have REM sleep and non-REM sleep, and we cycle through the REM sleep and non-REM sleep every 90 minutes or so. So for an 8-hour period, you have about 4 or 5 of these cycles. We notice that REM sleep happens mostly towards the end of the night, and deep sleep happens at the beginning of the night. As we grow older, the percentage of deep sleep and REM sleep it changes. So you'll notice when we're born, we have about 20% to 30% REM sleep. This is slow wave sleep, which is another way of seeing deep sleep. It's about 40% of your night when we're young. And as we grow older, you'll notice that REM sleep doesn't change that much, remains about 20% or so over the course of our life, but deep sleep decreases quite a bit. Usually by the time we're in our 60s, we have only about maybe 20% deep sleep, and by the time we're in our 80s, maybe 10% deep sleep or so. What does change a lot as well is this blue line here. This is short for wake after sleep onset. So after you fall asleep, you wake up in the middle of the night. When we're young, we don't have much of that. We just sleep through the night. As we grow older, we wake up in the middle of the night quite a bit. By the time we're in our 70s or 80s, it's estimated to be about 15 to 20% of the night is spent awake. And this is just normal process of aging we all go through. All right, so as I mentioned, sleep is divided into REM sleep and non-REM sleep. REM sleep is where we do most of our dreaming. To prevent us from acting out our dreams, we lose our muscle tone, so we're almost paralyzed during that time. REM sleep is where all the information you got during the day is being processed. That's usually the time of the night that happens. Non-REM sleep, though, is where the restorative function of sleep comes through. And like I said, we cycle through that every 90 minutes or so. So, is sleep important? Well, we don't really know why we have to sleep for all this to happen, but we all know what happens if we don't sleep. So we know, for example, if you don't sleep, you become moody, you lose your concentration, you forget things, become anxious, you become depressed. There's a lot of GI issues that occur if you don't sleep well. We gain weight, we have a hard time losing weight. There is actually some enzymes that are released if we wake up, and these enzymes make us even more hungry, so we go eat more. And a lot of people will say, I wake up in the middle of the night and I head straight to the kitchen to have a snack. So with insomnia, if you don't sleep well, you will eat more, you will gain more weight. Our immune system suffers as well. We find it harder to fight infections, and if we do get an infection, it takes longer to recover. And then we have all the heart issues that we are going to be talking about today. All right, so what happens to the heart during sleep? So sleep is divided into REM sleep and non-REM sleep. Non-REM sleep is the part of the night where everything calms down. So there's something called the sympathetic nervous system and the parasympathetic. The sympathetic is the part of the nervous system which is the active one, where the fight or flight response that you have. So your blood pressure goes up, your heart rate goes up. During non-REM sleep, all this is calmed down. The parasympathetic activity is the part which makes you rest and relax. So you notice that your blood pressure goes down by up to 30% sometimes. Your heart rate goes down also by up to 30%. It's not unusual to see heart rate in the 50s and 60s when you're asleep. I've seen heart rate as low as 40s, and that's totally normal at night when you're sleeping. Your metabolic rate goes down, your cardiac output goes down as well. So everything calms down during non-REM sleep. So the studies that look at morbidity and mortality make us believe that sleep is like a safe haven for us. If you think of all the cardiovascular deaths that occur during on average, only 8 to 12% of those occur when you're sleeping. The rest occur when you're awake. If you think that an average person spends about a third of his life sleeping, the ratio is pretty good here. That non-REM sleep is really protective for our heart. During REM sleep, though, things are a little bit different. There's a lot of activity, your heart rate goes up, your blood pressure goes up, almost to the awake level. And if a cardiovascular event is going to occur during sleep, it usually occurs during the REM sleep. And that's why I mentioned the REM sleep occurs towards the early morning hours, the latter part of the night, and that's usually when we see the cardiovascular events occurring as well. All right, so what's important? Quality sleep or quantity of sleep? That's been quite a big debate that we've had, and it turns out that both are very important. So if we talk about quantity, when we're really, really young, we need up to 14, 15, 16 hours of sleep. And as we grow older, our hours of sleep decrease. By the time we're adults, an average is 7 to 9 hours, maybe 7 to 8 hours of sleep. And this is average numbers. Some people are different, but these are the average numbers. So if we look at sleep quantity, an average adult needs between 7 to 9 hours. If you don't get as much sleep, we find that it's very detrimental to your heart. So we've seen blood pressure go up, we've seen cardiac events occur, and there's actually a study that showed that in men who sleep consistently less than 4 hours a day chronically, they have a 2.8 times likelihood of dying within the next 6 years. And for women, it's 1.8 times. So short sleep is bad. And so with short sleep, we see the heart rate go up, we see your sympathetic activity go up, we see a lot of inflammation in the body, which is a marker for vascular damage. And interestingly enough, we see increased risk of diabetes. So for people who sleep less than 5 or 6 hours consistently, they have about 2 times likely to develop diabetes. Interestingly enough, for people who sleep more than 9 hours consistently, they have 3 times as much likelihood to develop diabetes as well. So sleeping longer is not necessarily a good thing. And anything that disrupts sleep or makes it short can lead to that. So for example, it could be environmental issues where your work schedule doesn't allow you to go to sleep longer, or your family surroundings doesn't allow you to go to sleep. It could be just that you can't sleep because of insomnia, or your sleep is being disrupted from other conditions like sleep apnea, for example. I mentioned for people who sleep more than 9 hours, there's a 1.57 times likely to develop heart disease and 3 times likely to develop diabetes. Not exactly sure why that happens, but the theory is that the conditions that lead you to sleep for a long time are probably associated with these metabolic conditions as well. All right, as far as quality goes, though, if your sleep quality is disturbed, that also is problematic with the heart. So we see a lot of conditions that that disrupt your sleep. Sleep disorder, breathing is a very big one, which is sleep apnea or snoring. Restless legs or limb movements at night disrupt your sleep at night as well as insomnia. So why is sleep important for cardiology? All these reasons that I mentioned, blood pressure can go up, risk for heart attacks, risk for arrhythmias, especially atrial fibrillation. You can have right heart failure, left heart failure. Because of the low oxygen level during the night, your blood can become thicker, can lead to strokes or diabetes, or sometimes we even see sudden death occurring. And the prevalence of sleep apnea in these conditions are also high. So for patients who have drug-resistant hypertension, we see a likelihood of 83% of having sleep apnea. For patients who are obese, 77% having sleep apnea. Patients with heart failure have a 76% chance of having sleep apnea. Patients with pacemaker, atrial fibrillation, diabetes, the levels of sleep apnea or the prevalence of sleep apnea is quite high. So it's very important when you have someone with any one of those conditions to think of sleep apnea as well. There is a big relationship between sleep and high blood pressure. I'm going to go through this very briefly as Dr. Kim will be talking about this in more detail, but there is a big relationship between sleep and hypertension. We know, for example, that if you have sleep apnea, the drop in blood pressure at night when you're sleeping doesn't happen. And for patients who treat their sleep apnea with CPAP, there's a modest drop in your blood pressure. So we see that blood pressure in general going down by almost 11 millimeters of mercury. We see an increased risk of cardiac events, heart attacks, and people who already have coronary disease, if they have sleep apnea as well, can easily have another cardiac event as well. And coronary artery disease in itself can worsen the level of sleep apnea that you have. Heart failure and sleep apnea are very closely related, and if you have sleep apnea and heart failure together, your risk of mortality increases quite a bit. In fact, one specific form of sleep apnea, which we call central sleep apnea, is a very good predictor of mortality. And we know that if you treat those patients with CPAP, you improve the cardiac function, you improve their exercise capacity, their blood pressure gets better, and their quality of life improves in general. Very strong relationship with arrhythmias, particularly atrial fibrillation. There's up to 4-fold increase in atrial fibrillation in sleep apnea, and there's a higher risk of sleep apnea in atrial fibrillation patients as well. And if you get someone with atrial fibrillation after you cardiovert them, there's a very high risk that they can redevelop atrial fibrillation again after if they have sleep apnea. And then we see other arrhythmias that can occur as well. We see bradycardia, we see ventricular arrhythmias, we also see pauses that can occur at night as well. All right, so I've spoken a lot about obstructive sleep apnea, and this is one of the main conditions that we see particularly associated with heart issues. It is repetitive collapse of the upper airway during sleep. It occurs in up to 15% of men and up to 20% of men, up to 15% of women. What that is normally, as humans, we like to breathe through the nose. When you're breathing through the nose, your mouth is closed all the way, and you'll notice that your tongue fits perfectly inside the mouth. We almost think of your mouth like a suction cup holding your tongue in place. If you ever have a cold or allergy or sinus infection, then you open up your mouth to breathe. We all do that. When you go to sleep at night, you still try to breathe through the nose, but if you can't move enough air through the nose for whatever reason, then you open up your mouth. Once you do that, your tongue is no longer supported, and the tongue falls back and crowds the back of the throat here. So this area becomes totally obstructed. Air going in through the mouth, it causes the roof of the mouth to vibrate, and that's where the snoring sound comes from. But because of this blockage, your oxygen level starts dropping. Your CO2 level goes higher. If someone is watching you, they would see some period of snoring and then a pause in the breathing. And then all of a sudden, your brain starts realizing, hey, you're in trouble here, you're not breathing. So you wake up, take a couple of deep breaths, usually a gasp or a cough or a choking sound in the middle of the night, and then you go back to sleep again, and the cycle just keeps repeating over and over all night long. So at the end of the night, you've been in bed for so many hours, but you don't get a whole lot of rest out of your sleep, and that's why you're tired the next day. More important than that is what we talked about, what it causes to the heart. We have a sleep lab. It's present in the Macmillan building right there behind the hospital. Very nice hotel room. And there's usually a technician sitting outside who's monitoring all the data that we get during the sleep. Nowadays, though, most of the sleep studies are done at home. So there's a whole bunch of studies that can be done at home, different brands and so forth. We use something called the WatchPad, which is a small device, sits on the wrist. Few wires come out of it. We show you how to put it on. You take it home and sleep with it one night. We're usually able to detect sleep apnea with that. There is even a disposable version that we can mail to you, and you just throw it away the next day. Treatment is in 3 different forms. Either a CPAP machine, which I'm sure everyone has heard about. There are some dental devices that can be used as well. There are some surgical options. CPAPs come in different brands, different versions. Small device sits on the bedstand next to you, plugs into the wall. And we have these new ones that are called travel CPAP machines now. They're really, really small. They're very easy to pack and take with you. So the excuse of, I can't carry this with me when I travel is not there anymore. Usually, the way they work is they provide air, just regular room air under pressure through the nose to keep the airway open. So it's like blowing air through a balloon. You blow the air through the balloon, it kind of holds itself up, so prevents it from collapsing, and then you breathe much more comfortably. And that way, the airways are more patent there. Many different kinds of masks on the market. Some of them fit inside the nose, some under the nose, some around the nose, some around the mouth, some around the nose and mouth. Hundreds of them. We've tried to figure out one that works the best for whoever uses it. There are also some dental devices, so some people can elect to see a dentist. The dentist would make a mold of your teeth, and then they fit you with one of those devices. They usually have some sort of mechanism on the side that pushes your jaw forward, and by doing that, moves the tongue away from the back of the throat and hence opens the airways in the back there. And lastly, we have some surgical options. One of the common surgeries that used to be done is removing the back part of the roof of the mouth, and it makes this area much wider. There are some strips that we used to put in the palate to stiffen the palate so it doesn't collapse. The most common surgery done these days is the Inspire device, which is a small pacemaker-like device, goes under the skin, and a couple of wires come out of that. One touches one of your breathing muscles, the other goes all the way up to the base of the tongue. And then you get a remote. When you go to sleep at night, you turn it on. What that does is that senses your breathing and sends a signal to the tongue to move out of the way. So when you're breathing, the airways are much open. All right, just changing gears. What if you can't sleep at night, have insomnia? So it's unable to fall asleep, or after you fall asleep, you wake up in the middle of the night multiple times, or you wake up too early and can't go back to sleep again. What causes that? Well, there are theories, but the current theory is there are some predisposing factors that cause you to have insomnia. So elderly age, obesity, female gender, anxiety, depression, these are predisposing factors, but having those predisposing factors in themselves do not cause insomnia because you never reach that threshold of insomnia. And then some sort of stressor occurs, a precipitating factor occurs that pushes you above that threshold. Some sort of life stressor, a loss of a loved one, moving from your current place of living, a new job, a new grandchild. Something happens that makes you unable to go to sleep. We've all experienced that. Usually whatever it is that happens, after a while, it's no longer that significant, or you don't think about it anymore, but then we develop actions or perpetuating factors that keep the insomnia going. So a good example, for example, the person who would wake up at 6 in the morning and go to sleep at 10, let us say he had an event of some sort. He got a new job or lost a loved one or whatever, and he couldn't sleep for a couple of days. Well, he feels tired. So instead of going to bed at 10 o'clock at night, he goes to bed early. He goes to bed at 9. And obviously, he's still having a hard time sleeping. So instead of waking up at 6, he wakes up at 7. So all of a sudden, 10 to 6 has become 9 to 7. From 8 hours, he went to 10 hours in bed. Well, that's not very helpful because he's going to bed before, remember the clock I mentioned before, he's not ready to sleep yet. So his sleep is very disturbed. So he's still tired. So he ends up compensating for that by taking an extra cup of coffee and maybe taking a nap in the afternoon. Well, taking a nap in the afternoon disturbs his sleep even more because his need to sleep is now less. So what this person is doing is he's spending much more time in bed. He's spending awake time in bed, which disturbs his sleep. And he ends up maybe playing on his phone at night, an iPad, on a computer. All these emit light. And again, that disturbs the sleep even further. So all these habits that a person develops keeps the insomnia going, and that can keep going for years and years and years, and this habit just become part of his normal routine after that. To fix that, we addressed all those issues. So we talk about sleep hygiene, try to correct all these habits that this person has developed. There's something called cognitive behavioral therapy where we try to manipulate his bedtime and wake-up time to try to, again, correct those changes that he went through. The problem frequently is that by the time they see us, they've had insomnia for so long that many patients are not willing to make all these changes and sacrifices. So frequently we add also some pharmacological agents or medications to the regimen to help them at least jumpstart the treatment. So if you wanted to have a good night's sleep, there are certain rules you need to follow. Select a standard wake-up time. This is very important. That is to retrain the clock that you have in the brain. And this has to be, regardless of the sleep you got, and weekdays, weekends, it should be the same time all the time. Use the bed only for sleeping. Don't eat, read, or watch TV in bed. And this is very important because you don't want to make an association with the bed with awake activities. Get up when you can't sleep. Same concept. You don't want to associate the bed with lying in bed frustrated. So if you go into bed at your specific bedtime and you can't sleep, give yourself 10, 15 minutes. If you can't sleep, you get up, go sit somewhere else, and then come back when you are able to fall back asleep again. Worry, plan, etc. in bed is a problem for the same reasons. Avoid daytime napping, and we discussed the reason why that is the case. And go to bed only when sleepy. So if you're not sleepy, you don't have to go to bed just because. Many of my patients that I see go to bed because they're done with the day. All right, it's 9 o'clock, I have nothing else to do, might as well go to bed. And the problem is they lie in bed for hours and can't go to sleep. And so if you're not sleepy, don't go to bed. Limit caffeine, alcohol, and nicotine. Sleeping pills, that's controversial. But if you use them consistently, you become dependent on them. Exercise is important. Having the bedroom dark and quiet is very important, and a little bit on the cooler side if possible. And sometimes what disturbs your sleep at night is you get hungry, so a small snack in the evening is sometimes quite helpful as well. Thank you.
Thanks, Kali. That was excellent. It's a whole new world. And unfortunately, my parents didn't know those rules back when I was young. I might be a different man now. Our next guest speaker is Dr. Kim. Gene Kim has been around here for 20 years. He's an electrophysiologist, something that he's a cardiologist, board certified, but electrophysiology is talking about arrhythmias. It's a whole area that kind of has blossomed, and Gene's one of the top guys. We're very fortunate to have him down here. He went to Brown as an undergrad, and Brown is med school. Then he trained he went to school at USC, another Trojan, and then did his postgraduate training, USC, Harbor General, and also the Good Sam Harbor program. And he got all the stuff done that he needed to, because that means going beyond cardiology, he had to do the electrophysiology. He's done a great deal of work. He's really very prominent here and very busy. Gene, we welcome you to speak.
Hi, I'm Gene Kim, and thank you, Dr. Lurie, for that kind introduction. Thank you for inviting me and allowing me to participate in this community lecture series this evening. And also thank you, Dr. Eltwell, for that very comprehensive and informative talk on sleep and sleep disorders. This evening, I'm tasked on talking further in depth about sleep and cardiovascular diseases. In particular, how sleep disorders impact your heart, healthy sleep habits for better heart health, and reducing your risk for cardiovascular disease. As Dr. Eltwell showed earlier, sleep plays an integral role in almost every body system within us. And a lack of sleep or poor sleep quality will increase the risk of problems and issues within these systems. For example, in the neurologically or in the mental health, poor sleep or lack of sleep can cause anxiety, depression, as well as memory loss. So, and then it can also affect the endocrine system and cause metabolic syndromes, diabetes, and then tonight's talk regarding cardiovascular diseases, such as high blood pressure, heart attacks, coronary artery disease, and arrhythmias. So over the last several decades, there have been things that physicians, cardiologists, as well as patients have been focusing on to try to reduce cardiovascular issues. From the AHA, they have Life's Essential 7 steps to try to reduce coronary artery disease or cardiac issues. So they would include things as managing your blood pressure, controlling your cholesterol, reducing your blood sugar, having a good healthy diet, losing weight and maintaining a good healthy weight, staying active, and then stopping smoking if you are smoking. And that's kind of what has been recommended over the last several decades. Then in 2022, AHA came out with new recommendations, and they added one more item to focus on for preventing cardiovascular issues, and that was sleep. And the reason they added sleep was over the last several years, there have been more studies showing a relationship between poor sleep or lack of sleep with cardiovascular diseases. Also, unfortunately, there's been limited evidence that improving our sleep improves cardiovascular health. However, there is this association. And over the last several years, there have been more studies being performed in light of this. And so hopefully we'll have more information and a better understanding of the mechanisms and relationships between sleep and cardiovascular disease. As Dr. Eltwell mentioned, sleep is a fundamental requirement of life and integral to our health. As he mentioned, the goal is typically about 7 to 9 hours per night. And it's often easy to quantify sleep in terms of duration, but more importantly, we need to also, as Dr. Eltwell mentioned, focus on the quality of the sleep, the efficiency, and night-to-night regularity. As he talked about with the circadian rhythm, the sleep-wake cycle or the day and night cycle, disruptions of that have been shown to increase cardiovascular disease and also sleep irregularities. And then he talked about insomnia, restless leg syndrome, and sleep apnea. So I'm just going to briefly go over that. So poor sleep and its effects on the body and in particular cardiovascular health, it increases inflammation. It disrupts the autonomic nervous system, as he mentioned, the fight or flight versus, which is the sympathetic versus the parasympathetic, which causes the body to relax. It also can affect the vessel dysfunction. Typically, it can cause hardening of the arteries. It can also affect the arteries' responses to certain hormones and chemicals. Typically, it would cause these vessels to dilate, but in situations where there's poor sleep, it can have a paradoxical effect and cause those arteries to constrict rather than dilate and relax. It can affect the metabolic process, diet, depression, and cause poor mental health. So in terms of like the circadian rhythm that Dr. Eltwell mentioned about the day and night, there have been studies showing that people who work the night shifts have increased risk of cardiovascular diseases. So occupations in healthcare, such as nurses, physicians, paramedics, as well as the aides and other personnel in the hospital, are at greater risk. Those in protective services, such as police officers, firefighters, and then those doing customer service support. And shift work has been shown that it increases the risk of coronary artery disease, oftentimes, and also related to hypertension, heart attacks, and strokes. And it seems to be dose related in terms of the more night shifts you're working and the more years of night shift you're working, it increases your risk of coronary artery disease or cardiovascular disease. It's been shown that patients or people who do night shift work, there's greater inflammation. It can be measured in their blood work. They can have elevated CRPs and also elevated cholesterol levels. So the shift work, it disrupts your sleep patterns and indirectly can cause you to gain weight, unhealthy in terms of less activity and your eating habits. And these indirectly can lead to coronary artery disease or atherosclerosis. It can also affect the circadian rhythm, as Dr. Eltwell mentioned, and affecting inflammation in the autonomic system. Interestingly, just an hour change that happens with daylight saving has been shown to increase cardiovascular risk. There have been many studies looking at this, and with the Monday after daylight savings, there's an increase in out-of-hospital deaths, there's increased risks of strokes, as well as motor vehicle accidents. There have been studies looking at myocardial infarctions or heart attacks after daylight savings, and there were regional studies and small studies that suggested that there was an increase in heart attacks after daylight savings. However, just actually a week and a half ago, it was released from the researchers at Duke. They looked at 10 years of registry data from all the hospitals and cath labs in the United States, and they looked at the data to see if there was increase in myocardial infarctions the week before, the week of, and the week after daylight saving. And they found that there was actually, at this time, no difference. So that's the largest evaluation that we have. As Dr. Eltwell mentioned, long sleep duration also has increased cardiovascular risk. When there's greater than 9 hours of sleep, it increases the risk of high blood pressure, coronary artery disease, strokes, heart attacks, atherosclerosis, and heart failure. And so there's like the sweet spot or the Goldilocks where we want to try to get 7 to 9 hours of sleep. Now that's a general rule. It's not, everybody's a little different, but if we have less than 6 hours of sleep, or less than 7 hours of sleep, there's increased risk as well as greater than 9 hours. And they believe that sometimes it could be due to other chronic illnesses that make you want to sleep longer and be in bed longer. But as Dr. Eltwell also touched upon, it could be just the quality of sleep, disruptions of sleep that could cause you to be in bed or sleeping longer hours. So Dr. Eltwell did talk about sleep and hypertension. There have been studies showing that when people sleep less, their blood pressures will be elevated. And when the patients get a good night's sleep, their blood pressures can decrease. And high blood pressure is one of the most prevalent cardiovascular risk factor, and it's something that can be affected or managed. So, and and hypertension can lead to coronary artery disease, atrial fibrillation, heart failure, stroke, dementia, and then can also cause kidney disease and cause increased mortality. So what is high blood pressure? Normal blood pressure is recommended 120/80. Elevated blood pressure is 120s over less than 80. And then stage 1 hypertension is 130s/80s. And then stage 2 is when the systolic blood pressure is greater than 140 or the diastolic pressure is greater than 90. And the main goal is to keep our blood pressure below 130/80 for most adults. And then to touch upon dietary approaches, there's the DASH diet, which is the dietary approaches to stopping hypertension. It's more of a general recommendation. It's not very, it doesn't go into very specifics, but the general philosophy is we want to increase the fruits, vegetables, whole grains, the low dairy foods, fish, poultry, nuts, and beans, and also limit the sugar sweet foods, beverages, reduce our red meats and added fats. Lastly, we want to reduce the sodium intake, adopt a moderate physical activities and manage stress, and reduce and eliminate alcohol intake. So just diagrammatically again, normal blood pressure, we want 120, less than 120/80. Elevated pressures, 120s to the 120s/80. And that's kind of the goal. If you're on medications, we want to try to get your blood pressure 130s/80 or less. Sleep and coronary artery disease. With lack of sleep or decreased sleep, there's more coronary atherosclerosis noted. There's increased inflammation. Decreased sleep affects the lipids, the cholesterol levels, and it can affect the sympathetic nervous system, as Dr. Eltwell went over, the sympathetic and the parasympathetic balance. So with decreasing sleep, it can affect the sympathetic, increase that tone. There's increased fight or flight responses. It can also increase the amount of cholesterol produced, and then also the immune system. And that will ultimately lead to inflammation around the vessels, plaque buildup, and increased risk for heart attacks and cardiovascular disease. In terms of sleep and atrial fibrillation, as Dr. Eltwell went into much detail with obstructive sleep apnea, it's associated with hypertension, heart failure, and atrial fibrillation. And it is brought on because of the low oxygen levels and the high carbon dioxide levels. It can affect the autonomic nervous system. It increases the work on the heart, it increases the left atrial size, scarring, and can lead to these types of arrhythmias. And when we treat patients with the CPAP, it's been found that it can eliminate or reduce the atrial fibrillation, especially after cardioversions and ablations. So patients who have sleep apnea and are appropriately treated with CPAP, they have had better outcomes after ablations and cardioversions. And it's not clear the exact mechanisms of these reductions. This is still an area that needs to be further investigated. When we have patients with sleep apnea, should we be screening for atrial fibrillation? There is a relationship, and so there is benefits in screening. But in the other direction, screening for patients with atrial fibrillation, if we screen for sleep apnea, we find that there is a high percentage of patients with atrial fibrillation and sleep apnea. So many of our patients with atrial fibrillation are referred to Dr. Eltowil to undergo sleep study and to be evaluated for obstructive sleep apnea. And many, we find, have sleep apnea, and with treatment, some of those patients, or many of those patients, will reduce their atrial fibrillation burden. So when we try to screen, some of the easiest ways to screen for atrial fibrillation is just checking your pulse. You can check your pulse at the wrist and count the number of beats that you feel for 15 seconds and multiply by 4, or for 30 seconds and multiply by 2. There's also other newer technologies. Over the last 10 years, there's something called the Cardia app, where you can put your fingers on these 2 electrodes and be able to see your heart rhythm. Also, over the last few years now, many have smartwatches. I see many patients in the office with their smartwatches and their recordings, and they will show me pages and pages of this information to see if they have atrial fibrillation or other arrhythmias. Other things that can be placed are something called, there's extended heart monitors. There used to be electrodes that we would place and patients would wear for 24, 48 hours. Now with these extended heart monitors, they can wear these for up to 2 weeks. They are waterproof. Some of them you can swim with, others you have to remove when you're swimming, etc. So atrial fibrillation, it's one of the most common arrhythmias in the United States. There's about 5 million people with atrial fibrillation, and probably they think that maybe actually as high as 8 to 10 million people in the United States with atrial fibrillation, and the remaining 3 to 5 million may just be undiagnosed asymptomatic atrial fibrillation. Atrial fibrillation in relationship to sleep apnea and with sleep is often related to just the increased work on the heart and causing increased fibrosis or scarring within the heart. Common symptoms with atrial fibrillation is you feel the irregular heartbeats, the racing heartbeats, fatigue, lightheadedness. Some patients will complain of chest discomfort and shortness of breath. There are also many patients who are completely asymptomatic and unaware of their atrial fibrillation. We see patients referred who had gone for elective surgery or colonoscopy, and they were found to have atrial fibrillation and then are referred to us. Atrial fibrillation, so typically the heart should beat at about 50 to 100 beats per minute. The sinus node, which is your own pacemaker cells, they're here in the right upper chamber. They'll send signals down to the AV node, the connection between the upper chamber and the lower chambers. That sends signals down to the bottom chambers, and then blood gets pumped to the lungs and to the rest of the body. But in atrial fibrillation, there's areas that start firing on their own, and then your upper chamber's beating at 250 to 400 beats per minute. And as that fires, it's causing erratic heartbeats. The AV node, the connection between the upper chamber and the lower chamber, does not allow the heart to go at the bottom chamber to go at 250 to 400 beats per minute. It will block many of those signals. but it will cause this irregular heartbeat. Some patients will say that they feel like there's a fish in their chest and it's just flopping in their chest. So with atrial fibrillation, it increases the risk of stroke and often requires blood thinners such as Eliquis, Xarelto, Pradaxa, or Coumadin or warfarin. Many of you may have family members or others that you know that are on that or may actually be on these types of medications. Atrial fibrillation, it can be paroxysmal or persistent. So paroxysmal is just, it happens intermittently and the body corrects itself and it returns back to normal. In some patients, it's persistent and continues on. If it continues and they're on blood thinners, we can do what's called a cardioversion, where we electrically shock the heart back into normal rhythm. You can also be on stronger medications or consider what's called an ablation, a surgical procedure to try to get rid of the atrial fibrillation. For patients who are at risk of having a stroke but can't tolerate the blood thinners or at high risk of bleeding, they may be a candidate for left atrial appendage closure device implantation, something called the Watchman or an amulet device. So this is just an example of an ablation. In terms of the atrial fibrillation, typically is occurring in the left upper chamber here, and that's where the, oops. Oops, okay. I think I'm going to need a little help here. Thank you. So we believe the triggers for atrial fibrillation are coming from this left upper chamber and by the pulmonary veins where the oxygenated blood is coming from the lungs into the heart. That's where we believe the triggers are. And so 30 years ago, we started ablating with radio frequency. We were burning the cells around those areas. And then about 15 years ago, we started using cryo, where we were freezing the cells to try to eliminate the atrial fibrillation. By doing this, in about 70–80% of cases, we can eliminate the triggers for atrial fibrillation and eliminate the atrial fibrillation. Unfortunately, we still have not figured out all the mechanisms, all the areas that can cause atrial fibrillation. So it's still in 20–30% of patients can still have recurrence of atrial fibrillation despite an effective ablation. Just recently, last year, we started using pulse field ablation that was approved here in the United States. Torrance Memorial, we've been using it since December. Pulse field ablation is like essentially electrocuting the cells that cause atrial fibrillation. So instead of heating it up or cooling it, it's non-thermal. It causes less collateral damage. It doesn't affect the nerves or the esophagus that's by the veins. The other thing is with those patients who cannot tolerate the blood thinners and who are at increased risk of bleeding, there's another procedure called the Watchman or the amulet that could be performed to eliminate the need to be on blood thinners. So there's this little outpouching called the left atrial appendage. That's the area that causes clots to form in atrial fibrillation. So by occluding that area, it prevents the clots from escaping and causing that clot to go to the brain and cause a stroke, or that to go to the heart and cause a heart attack. So this device can be delivered and placed. Patients will still need to be on blood thinners or aspirin and Plavix, what are called antiplatelets, for a couple of months while the skin grows over it. But after that, they just need to be on a baby aspirin, and it reduces their stroke risk. Dr. Eltwell kind of went over the tips for better sleep. There's things that we should try to avoid, and then things that we should work on. So as he mentioned, we want to avoid drinking coffee late in the afternoons, or avoid drinking alcohol. We think that alcohol will make you relax, but it will disrupt your sleep and sometimes have you wake up in the morning or in the middle of the night. And also, exercise is good, but we don't want to be exercising too close to bedtime. It just gets our whole body revved up and difficult to go to sleep. Watching television and then social media. And as he mentioned, having a cool temperature, having a daily regimen of brushing your teeth, getting cleaned up. Some people will take a warm shower or a hot bath before going to bed. And then having that regimen in terms of time as well. Some people, it's like they have a busy week, they have their nighttime regimen, and then there's the weekend regimen. But that disruption of and irregular sleep patterns may also be detrimental to the heart. Meditation and healthy foods. So in terms of sleep, the sleep has been added as one of the eighth factor that we want to modify. And we are still learning about the mechanisms, but there is a high relationship, and sleep can essentially affect every single one of these. For example, as we talked about, sleep can affect the blood pressure, it can affect our cholesterol levels, it can affect our weight. If we have poor sleep and poor eating habit, can lead to poor eating habits. It can affect our sugars, and then if we're too tired, we won't want to exercise, or we won't want to eat well. So that's the reason that sleep has been included as one of the factors that we want to modify and watch for good overall health as well as good cardiac health. In terms of resources, the American Heart Association, the Life's Essential 8, they have these educational handouts, for example, on how to get healthy sleep. They talk about, dimming it, setting it, having that routine and time, creating that nighttime regimen, and then blocking it out, avoiding television, using the phones, etc. And then if you go to that site, they have these educational handouts for all 8 of those factors. Thank you.
Well, I want to thank both of you guys. Those are fantastic presentations, and great to integrate all these systems that we never knew before. Now there's going to be about a 3-minute break. I think there's a few suites there, and I probably should have said before, the restrooms are back there. And you got cards to fill out with any questions, so there'll be people coming by to pick them up and give them to me, and we'll have a question and answer period. 3 minutes, counting. Okay. Oops. Oh, okay. Sorry about that. Okay, well, we've got quite a few questions, and they're dynamic. I want to thank, again, our media services, Mitch. As you saw, he came through with the emergency for us, and that's always the case. They do a phenomenal job, so I appreciate it, Mitch. Good job. All right, several questions. Oh, you bring in another? Okay. I don't know that we'll get to all of them, and so you'll know if you don't feel crowded. There's 48 people watching this on Zoom too, so it's a big crowd. For Dr. Kim, if an ablation is not successful, does the patient go immediately, well, what happens immediately? They're asking about heart failure, but what happens after, what do you do after failed ablation?
So unfortunately, the ablation is not always 100% effective. If we will try medications in conjunction after the ablation, and there's also what's called the healing process or a blanking period. So after an ablation, we usually will wait at least 3 months to see if it is healed So if you have atrial fibrillation in those first 3 months, we will often wait, and then we will try doing our cardioversion where we shock the heart back into normal rhythm and then see if it stays in rhythm. Or we may add other medications to try to maintain normal rhythm and consider a cardioversion. However, if despite that it's still persisting, the other options are that we can do another ablation. The typical ablation I showed was targeting just the pulmonary veins. There are other areas within the heart that we can address and target, and sometimes that will improve the successes of the ablation after a second time. There's also surgical ablations that can be done by cardiothoracic surgeons on the outside of the heart. But now with PFA, pulse field ablation that was just approved last year, we can do a lot of the things that the surgeons were doing more safely within the heart internally. So that may become less of where we're referring to the surgeons. It's still rapidly expanding. There's more research being done, and there may be other tools. They've looked at laser and other modalities for ablations as well.
Thank you. Dr. Eltwell, this is for you, but it might take some of your urologic training. Elderly men don't sleep well, but there's a couple questions about getting up frequently during the night, and that affects the sleep. They say, the question is, what can be done about that? I think what I'll add to it is, what effect does that have? And I know you go to the urologist, but what can you do as far as the sleep interruption? Anything else?
So yeah, that's a big question. If you remember, one of the slides I put up there is awakening after sleep onset that increases as we get older, and about maybe by the time you reach 70 or 80 years old, about 15 to 20% of the night is awake time. There's a lot of reasons for this awake time. Some of it is just that your deep sleep has decreased quite a bit. Some of it is aches and pains, and a big part of it is getting up to go to the bathroom at night. Now, the getting up to go to the bathroom, it could be a urological issue. Definitely the prostate in men may be larger, and that might be contributing to that. But interestingly enough, sleep apnea itself can make you go to the bathroom frequently at night. And one of the good surprises that we get when someone is started on CPAP for sleep apnea, one of the more common things that they say is like, one of the best things here is that I don't get up as much to go to the bathroom anymore. So frequently they would get up maybe 5 or 6 or 7 times a night to urinate, and once they started on CPAP, that goes down to maybe once or twice only, and it improves quite a lot. Many theories about why that happens, but we do see it very frequently in older men.
Well, that's great. Good answer.
Thank you.
Is sleep apnea, is there a genetic component?
There is no genetic component, but we do see many family members with sleep apnea. Some of it just because of the facial configuration between family members are the same, so that the airways become narrow and they're seen in multiple family members, but also because it's such a common condition that it's not unusual to see multiple family members with sleep apnea at the same time. But it's not something that you inherit or give to your kids.
Is there a relationship of sleep apnea to Alzheimer's, dementia, cognitive decline?
There is a strong relationship with poor sleep with cognitive decline and dementia, yes. Not just sleep apnea. Sleep apnea eventually leads to poor sleep, which can lead to that, yes.
Dr. Kim, you didn't get off. Any sleep repercussions with bradycardia? In other words,
So usually with bradycardia, I don't believe there's any significant relationship with sleep or poor sleep or affecting sleep. As Dr. Eltwell mentioned, when we sleep, and especially during that phase where the parasympathetic tone is increased, it's not uncommon, actually, when we read these 24-hour reports or 7-day monitors, I will see patients, even their heart rates get as low as into the low to the mid to high 20s sometimes. But if they're asleep, they're asymptomatic, and during the day, their heart rate's 50s to 100s, that's okay and that's not uncommon.
Great. Well, both of you talked about shifts, et cetera, being effective. This is one I hadn't thought of. What about, did they study astronauts and the sleep quality during their flights?
I'm sure they have, but I'm not aware of the data, so I can't really speak to that.
My understanding is that astronauts are encouraged to maintain the same sleep-wake cycle as they would have on Earth, so to maintain that rhythm going.
So they should just treat those flights as like being at home. Yeah, that'll be easy. That's great. All right. Do all the shifts, we talked about night shift, do all the shifts, whether it be 11 to 7, 3 to 11, 7 to 3, can they all have the same problems? I realize if you're working 7 to 3, you don't interrupt your daily your sleep, but what about the other other off hours, 3 to 11?
So it went specifically in regards to night shift, but it did also say shift work where if it affected your cycles and also the circadian rhythm, it can have an effect. But I think the biggest impact was those that were working the night shifts or the overnight shifts.
I would assume that when I was a resident and all the residents I trained with should be having sleep disorders because the old days really were crazy. This is my opinion they're asking, but it's not really. Either one of you can pop up. What's the opinion of taking a melatonin supplement 30 minutes before sleep? Going to sleep.
So melatonin is an interesting medication, and it's a signal for the brain to start the nighttime activities, which is in human sleep. So melatonin, if you give melatonin to a nocturnal animal, for example, it will wake them up. So it's a signal to the brain, and it's a signal of night. Melatonin takes about an hour to an hour and a half to start working. So if you're going to take it, I would recommend you take it at least an hour before going to sleep. The problem with melatonin, or the main reason we use melatonin is for changing your circadian rhythm. So for patients who travel, for example, across time zones, and they have a hard time sleeping in a different time zone, we use melatonin frequently to adjust that circadian rhythm for them. It is being used frequently as a sleeping pill. Many times it is used as a sleeping pill because it is part of your nighttime routine. So, you locked the front door, you fed the dog, and you took your sleeping pill. Now it's time to go to sleep. As long as you check off all the boxes, you will sleep comfortably. In itself, though, it does have a little bit of a sedating quality, but its main effect is to adjust your sleep pattern and your sleep cycle.
Okay. This one, I think, well, let's answer this. Both of you, either one can pop up. Is gabapentin okay as a sleep aid? You want to say what gabapentin is?
So the receptors in the brain that promote sleep are GABA receptors, which gabapentin does end up stimulating there. And it does have sedating qualities. It is used for many other conditions. I know a lot of people do take it as a sleep aid. It is not well known to be a sleep aid. We usually don't prescribe it for that reason, but it helps a lot with other conditions that can disrupt sleep. So for example, patients who have restless leg syndrome or periodic limb movement disorder, we give gabapentin to control that, and that helps people sleep better.
And so indirectly, it can be a sleep aid, but it's not
Yeah.
I think that's good. Jean, the question is how much sleep should somebody have to prevent the buildup of coronary artery calcium, because everybody's getting calcium scans. Just if you want to elaborate on that, I know you talked about it.
So obviously, building up of calcium or coronary artery disease, it's multifactorial, sleep being one of the things that can contribute to it. The ideal amount is 7 to 9 hours, but it does have to be individualized. And not only is just the number of hours important, but the quality of the sleep or the efficiency of the sleep. But generally, 7 to 9 hours would be recommended. But if your calcium score is elevated, then obviously recommend seeing your primary care doctor or cardiologist for modifying other things that may slow the progression of worsening coronary artery disease.
Khalid, I think you addressed this, but just briefly again, what do you recommend, because the question is asked, to create a healthy sleep regimen? Is there an easy to-do list? I know you gave a lot of information, so what should we be doing? Dinner time, lunch, wake-up times? I know you addressed it.
So following a good regimen is important, and I mentioned those in the last few slides. Maintaining a strict going to bed and wake-up time is important. Keeping the bedroom nice and cool and dark is very important. I think out of all those, the important part is the schedule. Going to bed at a specific time, waking up at a specific time, and more important as well as avoid spending a lot of awake time in bed. So the biggest or the most patients that I see with insomnia in the office are people who are just retired, and they usually tell us, all my life I've been working so hard, I'm just looking forward to the time where I can finally sleep in, and now that I'm retired and I'm sleeping in, I can't sleep. And usually what happens is when they were working, they were spending their 7 or 8 hours in bed and then getting up at a very specific time, and their sleep was perfect. Then they retire, and all of a sudden now they're spending 9 hours and 10 hours in bed, and their sleep becomes very fragmented at that point. And frequently all we do is tell them, go back to sleeping the way you were when you were working, and your sleep will improve. So maintaining a very good sleep regimen, or what we call sleep hygiene, is probably what you need to do.
Thanks. I know that this was addressed during your talks, but both of you can give me an answer, I hope. This question is, are there studies to elaborate on females and studies that as far as a menopause group?
So hormonal changes can definitely affect sleep, and there are studies looking at that, absolutely. And if you remember my slide about the causes for insomnia, and I say there are people who are predisposed to develop insomnia, and part of it is the female sex is more predisposed to develop insomnia, and also advanced age is predisposing for insomnia. So once females develop menopause, they are more likely to develop insomnia as well.
From my research, I didn't come across anything to add to what Dr. Eltool just said.
Okay. Is staying in bed for a long time after walking, is that harmful? That's the question.
So the issue here is what we call conditioning. If you get someone who is very healthy, no sleep problems at all, and they get into bed, they start feeling sleepy even in the middle of the day, because there's an association of the brain and the bed with sleep. If you spend a lot of awake time in bed, then the brain gets a little confused. Is this the place where I stay awake, or is this the place where I read, or is this the place where I watch TV, or is this the place where I sleep? So you remove that stimulus of the bed to help you go to sleep. So I would say, yeah, spending a lot of time in bed is probably not a good idea, unless it doesn't cause any problems. Some people have back pain or joint pains and are forced to do so, and if that's the case, that's the case. We just have to live with it. But in general, spending too much awake time in bed is not desirable.
I hope that answers it. The last question will be, it goes back to the blood pressure, and the question is, why is there not a change or a difference in the recommendation for age or sex? But you gave the chart, and so.
So in terms of age and sex for blood pressure guidelines, so the guidelines are for just the general population. It's not specific for any age group or gender or any other conditions. So I don't believe there's any large studies that have been performed looking at specifically different goals of or targets for blood pressure based on age or gender or other factors.
Great. Okay, I want to first of all thank Khalid and Jean for doing this. And just to remind people here at Torrance, there are many places where if you have a sleep question or a rhythm problem, you're going to end up just seeing a pulmonary, not just, but you may just go to a pulmonary doctor at their office and kind of work that up, or go to any cardiologist, like I was a general cardiologist. But Torrance and these guys have developed programs that are unified and integrated, so you actually have a sleep program with Khalid and his colleague who actually specialize and are trained in sleep. And Jean is part of what, like I said, electrophysiology. You know, to have atrial fib, it's not something you can just look at and any cardiologist deals with. Electrophysiologists can treat it, can diagnose it, but can cure it. And so I think we got to appreciate the work that they've done. I also want to thank Mary and her team again for doing such a great job, and thank all of you for attending, and enjoy yourself. It's supposed to rain tonight.